So, welcome everyone. Thank you for being here. Today, our speaker is Dr. Pouya Sabouri. He's the Director of Proton Therapy at the University of Arkansas Medical Science and Proton Center of Arkansas. He will speak about the clinical evaluation of the SDX system for motion mitigation in IMPT. If you have any questions, we'll do just as usual. Please write them in the chat. You also have a Q&A available, and we'll answer them at the end of the presentation. Pouya, the floor is yours.
Thank you, Annabelle. You see my screen?
Yes, we can see your screen.
Thank you for the introduction and the opportunity to be here. So, respiratory motion introduces significant uncertainties in radiation therapy, particularly for thoracic and abdominal targets. And APM-TG290 is one of the reports on motion management for particle therapy. And APM-TG290 reports that breathing leads to organ deformation and transient density changes. And as a result, this causes tumor motion that varies considerably between patient to patient and between tumor sites. And because there is no consistent respiratory pattern, individual imaging and evaluation are also necessary. To quantify this, currently the standard of care is 40 CT, which does have certain limitations. But the idea is that the 40 CT captures the tumor motion over a period of time and correlates the motion amplitude with the tumor characteristics. And the variability in the motion has critical consequences. It can disturb the dose distribution that's planned, especially in particle therapy, where the changes in the tissue density or the target position can shift the Bragg peak. Factors such as variations in chest wall thickness, internal target displacement, and changes in tissue density must be accounted for in order to preserve the dose delivery accuracy. Ultimately, TG290 emphasizes the importance of comprehensive motion evaluation and planning strategies to ensure safe and effective treatment. Unlike photon therapy, particle beams are highly sensitive to tissue composition and density changes. Any variation along the beam path can shift the Bragg peak and significantly impact the dose distribution. This, as a result, makes the managed respiratory motion very important in particle therapy. According to TG290, respiratory motion introduces two categories of uncertainties. They classified as systematic and random. And systematic errors, they mentioned, stem from the discrepancy between the anatomy captured during planning, usually on the static CT, and the dynamic anatomy during the actual treatment. And these can be evaluated by comparing the static CT and the 40 CT data sets. And the impact depends, obviously, on both the extent of the motion as well as our ability to account for it during the delivery. And random uncertainties, or the interplay effect, are caused by the misalignment between the delivery of the pencil beam and the target motion. And the effect is very concerning in pencil beam because the dose is delivered in discrete spots. And as a result, PBS is more susceptible to motion-induced inhomogeneities. Even small timing matches between the delivery and the respiration can result in underdosing or overdosing. And so together, these uncertainties highlight the importance of individualized motion assessment, robust plan evaluation, and the potential motion mitigation strategies such as rescanning, gating, breath hold, and so on that we'll talk about. This slide is a figure from APM-TG290. And the first row here in this slide demonstrates how respiratory motion can impact proton beam delivery even when the target remains stationary. So in this simplified model they present, the red dot represents a fixed target. And then a high-density structure such as a bone is moving laterally in between the two phases, say T0 and T1. And an average CT scan ends up blurring this motion so that it's masking the actual motion of the bone. This scenario sets up a common challenge in proton therapy. So while the target itself moves, the changes in the intervening anatomy lead to fluctuations in the water equivalent path length, introducing the potential for significant dosimetric error. We'll see the impact of this in the next slide. So continuing from the previous slide, here we see the failure of the 3D proton plan when respiratory induced water equivalent path length changes are ignored. So here a single spot plan is created on the average CT because the average CT is masking the density variation caused by the lateral motion of the bone between the phases, say T0 and T1, the plan appears to be acceptable on the planning image. But when we recalculate the dose on the respiratory phases, we see on T0 and T1, the beam path traverses different densities, shifting the Bragg peak and causing the dose to miss the target. Even the 40 dose accumulation, which averages the dose across the phases, remains suboptimal. And the averaging doesn't fully recover the intended target coverage because the underlying water equivalent path length shifts are not explicitly accounted for. So this example emphasizes the key point from TG290 that planning on a blurred average representation can mask clinically significant uncertainties in particle range. And as a result, motion mitigation should definitely be considered. In the third row of the figure, TG290 explains how a 4D planning strategy can address some of these shortcomings on a 3D plan, as shown earlier. So rather than relying on a blurred average CT, the treatment is now planned on different respiratory phases individually or in a multi-CT data set. And you have plans, say, for example, that are robust on T0 and T1. And this allows the beamless to be tailored to the specific anatomy for each phase. And the resulting dose distribution, say the purple and the green spots, more accurately represent and match the target during both T0 and T1. When accumulated into a 4D dose distribution, this approach does offer a significantly better coverage compared to the 3D plan, even though if the target itself never moves. So this is a core principle in TG290 that by accounting for phase-specific anatomy, the 4D planning improves plan robustness against density and range uncertainties. And the interplay effect between respiratory motion and dynamic pencil beam delivery is simulated using the dynamic acquired 4D dose, which is the weighted average of the doses calculated on the 4D CT phases. So in this model, even though the 4D plan showed good average dose distribution across the phases, when we look at the actual delivery timing of the individual spots, this is random, could be random from fraction to fraction. And so each colored dot represents a unique delivery sequence. Some spots are maybe delivered entirely in phase T0, others in T1. And this randomness introduces a potential for under or overdosing within a single fraction, despite the fact that you may have an acceptable 4D dose over several fractions. So we see that while the average dose over multiple fractions may converge to your desired dose distribution, individual fractions may not be optimal, the individual delivered dose. And the takeaway is that the respiratory motion introduces significant complexity in proton therapy that affects both range, dose accuracy, and robustness. And as shown, even stationary targets can be compromised by the dynamic anatomy from respiration motion. And these challenges highlight the need for motion mitigation strategies such as breath hold to ensure safe and effective treatment. Grasberger studied how respiratory motion affects dose delivery in pencil beam for lungs cancers. They used the 4D Monte Carlo simulation and examined the interplay between dynamic target motion and spot scanning delivery, showing how the interaction can degrade dose uniformity, especially in a hypofractionated, say, few fraction treatments. They reported that some of the findings is that interplay can cause significant hot and cold spots in single fractions. Averaging over multiple cycles can help mitigate these effects, but may not fully eliminate them. And then large spot sizes and rescanning were found to help reduce some of these, the severity of the interplay. The figure that's being shown here is reproduced from their manuscript, and it's a good visual illustration of the degradation in dose uniformity from interplay. So in panel A to D, the dose distribution for single fractions with different starting phases you can see. And you can clearly see that the inhomogeneous dose patterns with both hot and cold spots regions inside the targets due to the phase offsets appear. In panel E to F, you have, after multiple fractionations, dose uniformity does improve significantly and converges to the planned dose, demonstrating the smoothing effect that's associated with the temporal averaging of multiple deliveries. However, if you still look, there is residual heterogeneities that can still be observed. And another important comment is to note that many physicians, from my experience, still expect individual fractions to be closely approximate the planned dose, particularly in hypofractionated or stereotactic regimens. And so this also highlights the critical need for robust motion management strategies, such as gating or breath hold. Respiratory motion is highly patient-specific. This is noted in TG290, where they mentioned that there is no generalizable motion pattern, and several factors contribute to the variability of the respiratory motion. These factors such as tumor size, stage, patient anatomy, breathing behavior. And these variations can occur both between sessions and within a single session, which pose a major challenge for accurate dose delivery, especially in proton therapy. Um, I've produced a figure here from Shaw, which shows electromagnetic tracking data of lung tumor motion collected over 4 consecutive treatment sessions. And electromagnetic transponders offer one of the most precise methods for real-time tumor tracking because it's capturing motion continuously and directly from inside or near the target. What's striking here in this figure is the degree of variability in the breathing pattern, not just between the fractions, but also within the individual fractions. Both the amplitude and the rhythm of the motion shift dynamically, underscoring how unpredictable respiratory motion can be, even under relatively stable treatment conditions. And this level of detail highlights the limitation of relying solely on pretreatment imaging and also reinforces the need for robust motion management, especially in particle therapy where range accuracy is very critical. There's a range of motion management strategies that can be used in radiation therapy. Each one of them has their own trade-offs and complexities, comfort, clinical feasibility, and so on. Particularly relevant to particle therapy, where respiratory motion introduces range uncertainty. For the left, we have common techniques that are on the left. We have common techniques that are more widely available. Abdominal compression limits diaphragm excursions, reduces motion, but doesn't eliminate it altogether. It can be uncomfortable for the patient, and it doesn't work equally well for all the sites. And gating attempts to deliver the beam using the specific respiratory phases. While conceptually it's elegant, it could be inefficient if the gating window is too narrow, and it may also be sensitive to irregular bleeding. Breath hold is one of the promising strategies among the techniques, and it completely pauses the motion, or it attempts to completely pause the motion, and has shown to be success in reducing those delivery uncertainties through, although it may extend the treatment time because the patient does need to go into multiple repeated breath holds. On the right, you have less common techniques that I won't describe here. One of the, I think, more research-oriented techniques is tracking. It's a very elegant method that does offer most, I think, adaptive option. But as TG290 reports, there is right now not a commercially available system for tracking. And in particle therapy, tracking does have significant complexities. So abdominal compression is one of the most common motion management strategies, especially for lung and upper abdominal tumors. And the technique aims to reduce breathing induced tumor motion by limiting diaphragmatic motion, typically using a belt or pressure device over the abdomen. This is the data that comes from a French study, which sorted tumors based on the SI location. It clearly shows that compression is most effective for tumors near the diaphragm, where respiratory-induced motion is very pronounced. In contrast, tumors located more superiorly, where motion is often driven by, say, chest wall or heart or rib movement, in these cases, you see minimal effect. So I've produced a figure from their manuscript. The left graph shows data from tumors located in the lower lobe. It's the reduction in the tumor motion. And on average, what you see is that abdominal compression reduced the motion by about 4 millimeters with statistically significant results. On the right, you have the reductions that were associated with tumors in the upper lobe and middle lobe that they reported. And on average, the average reduction was at most about 0.8 millimeters. That's average reduction was about 0.8 millimeters. So not very statistically impactful. So one of the conclusions that they reported here was abdominal compression is not a one-size-fits-all solution. Its effectiveness depends on where the tumor is. And so as a result, care must be taken to assess whether its use provides meaningful motion reduction for a given patient. In gated treatments, the patient breathes normally and the beam is turned on only during a predefined stable phase of the respiratory cycle. Typically, we use the end of exhale because that's the most reproducible phase. So while this approach does aim to reduce the impact of motion, TG290 does highlight several challenges. The first is that there's residual motion within the gating window, which can affect the dose accuracy. Second, the correlation between the external surrogate and the internal tumor is often imperfect and prone to change. And that's something that I'll discuss in the next slide, especially for deep-seated tumors or irregularly moving tumors. Third, proton delivery units lack real-time internal imaging. So it makes it very difficult to verify the target position during the beam on. And additionally, the gating approach introduces beam delivery inefficiency and may prolong the treatment time, especially if you pick a gating window that's very narrow. So these issues become more pronounced in hyperfractionated treatments where there's fewer fractions and so less opportunity to average out the delivery uncertainty errors. Furthermore, gating typically does require patient-specific optimization from window selection to motion reproducibility and so on. And lastly, the lack of real-time dose verification makes it difficult to confirm what was the dose that was actually given to the patient during the gated treatment. Regardless of the motion management technique that we choose, whether it's breath hold, gating, or something else, you usually do need a way to monitor the patient's respiratory motion in real time. And so this is where the idea of these surrogates comes in. There's a review by McClelland, 2013 paper regarding a review of motion models. And so there they define respiratory surrogates as a measurable signal that correlates the internal tumor motion and helps us estimate organ position throughout the breathing cycle. They classify surrogates in two broad categories. Internal surrogates are surrogates that are derived from inside the body and offer a more direct view of anatomical motions. So examples of these include implanted fiducial markers, fluoroscopy tracking of diaphragm, or vascular biophication for the hepatic or portal veins. On the other hand, external surrogates, these are easy to measure, but only approximate the internal motion. So examples of these are the variant RPM or respiratory bellows, optical surface monitoring systems such as OSMS or CRAT. It's important to note that spirometry measures the volumetric airflow at the mouth of the patient to estimate the lung volume changes. And it's considered as an external surrogate because it's being measured outside of the patient's body. But at the same time, it's measuring a signal that's highly correlated to the internal anatomy because it is the airflow of inside the lung. This is an image from a setup from a study in 2018 that we performed at the University of Maryland. And we directly compared 3 external surrogates in this study in a clinical environment. They were all simultaneously acquired. So on this volunteer, you can see the setup. You have the 3D surface signal over time, and it was captured using a prototype vision RT system that sits on the couch and is shown in the figure. Then you have a 1D amplitude signal from the variant RPM box that's also acquired simultaneously, along with the volumetric tidal flow signal from the SDX spirometry system. And all 3 of these systems were synchronized to evaluate how closely their signals correlate. And this allowed us to examine the differences in the signal characteristics, phase relationships, and signal drift across the systems, and all of which are very critical when selecting a surrogate for gated or breath hold treatments. This plot shows a time-based comparison between the 3 surrogate signals collected in our study. The black curve is the actual spirometry signal. That's our reference, reflecting the tidal volume. When we then try to use the 1D RPM signal and the 3D surface from the Vision RT system to model and predict the spirometry signal. And what we observed was that the Vision RT surface signal provided a closer match to the spirometry waveform than the RPM did. And this suggested that the higher dimensional surface tracking contains richer information about the breathing, likely to capture subtle chest and abdominal motions because breathing is at least induced by 2 actuators. And those were better in predicting the internal volumetric airflow than using a single marker trajectory such as the RPM. In this slide here, I show the scatter plots of the RPM signal or the Vision RT estimated signal versus the SDX signal. And so on the left, we have the variant RPM signal plotted against SDX. While the correlation is still pretty evident, we do see a larger deviation from the line of unity. suggesting that there is some discrepancy between the one-dimensional marker motion and the actual tidal volumetric flow. On the right, you see the same sort of comparison, but using a higher component surface estimated to estimate used to estimate the volumetric tidal flow. And so here you see the agreement is notably better, aligns closer to the line of unity. And so the results reinforce the fact that despite all these three surrogates trying to measure the same thing, the higher dimensional surface tracking offers a more accurate approximation of volumetric tidal flow. Some of the limitations with external surrogates I thought I provide here. So first of all, one of the limitations that McClellan points out traditional with spirometry systems is that they do drift over time. And this could be due to instrumentation errors or simply because of air leaks out of the mask, making the signal less reliable. There is also a study by Hoizak, which showed that the external signals don't always match what the tumor is doing inside. They found and report that there is usually phase shifts and varying correlations, meaning that the surrogate might be doing one thing while the tumor is slightly out of sync with that signal. Finally, I thought it's very interesting to show this plot by Malinowski. This is work done in 2012 at University of Maryland. And it shows how the correlation between the external surrogate and internal target motion is prone to change over time during the treatment. So each box here represents a 2.5-minute segment of a 10-minute block. So block 1, for example, is first 2.5 minutes. Block 4 is the last 2.5 minutes. And what you see here is that there is clearly, by the time that we get to block 4, the variability in tumor position has increased. This growing spread means that even if things start off well at the beginning of the treatment, there is a tendency to drift over time, and likely due to changes in the patient's breathing pattern, comfort, or tumor baseline positions. In fact, the study, they report that over 13% of these 10-minute blocks, the tumor had a more than 5 mm shift, baseline shift in its mean displacement. And that's significant in particle therapy. So the takeaway here is that the longer the treatment is, the more likely it is that the surrogate signal will degrade. And we need to be cautious about assuming that the external correlation versus with the internal anatomy is all constant. Let's look at how the SDX system tries to address some of these limitations with the traditional spirometry system. So for one, it uses a sealed mouthpiece and a nose clip, which help reduce the signal drift from air leaks, something that was flagged in earlier studies, including McClellan. It also includes pressure differential sensors, specifically the flesh type sensor that's shown here, that are designed to detect any drift in the signal during a breath hold. If it picks up a drift, the system will terminate the breath hold. There are 2 sensors mounted on the side of the SDX system to help with this detection. In terms of workflow, it's built around a short duration breath holds, which can help minimize the impact of baseline shifts over time. It also offers real-time coaching, which may help the patient stay more consistent from fraction to fraction. And since it's using breath hold rather than free breathing, it does avoid some of the issues that I mentioned regarding the phase shift between the internal motion and the external surrogate. There's a Swiss study by de Lombard where they evaluate the use of SDX for DIBH and VMAT breast treatments. They report good stability, no significant drift, and the breath hold blocks could be delivered pretty efficiently. They report within 10 minutes. So while no system is perfect, the SDX does implement a few technical modifications aimed at addressing the limitations that were discussed earlier. Let's walk through a typical setup process for the SDX system for breath hold treatments. First, we check if the patient is a good candidate for breath hold. Basically, what we find as a good candidate is if they can hold their breath for about 20 to 30 seconds. Next, the system does use video goggles to give the patient real-time feedback so they can match their breathing to the target level. We are usually aiming for about 75 to 80% of the deep inspiration capacity. Default is 75. And we don't necessarily want them to max out to be at their maximum level of intake. Rather, we want to be at a repeatable and comfortable level. There's a gating window that you select. It's a tolerance you can imagine. This is the default is 0.1 liters, but you can always select a tighter tolerance, especially for more sensitive treatments such as SBRT. And then finally, the planning CT is done while the patient is coached. The planning CT is done while the patient's coached through the setup with the spirometry and goggles helping to maintain the consistency. And the image shows how everything fits together. There's a mouthpiece, the nose clip, the spirometry sensor, as well as these feedback goggles that they all work in sync. It's a bit of a gear setup, but once the patient does get used to it, it is fairly effective. This slide is when we were still working on our manuscript in 2024, so it may need some updating. But the main point here was that at the time when we were doing our literature review, the clinical data on breath hold with PBS was fairly limited. And we had a few relevant studies. We found Evertson on DIVH for mediastinal lymphoma, Gorgeson on breath hold PBS for non-small cell lung cancer, and also Franciola for liver cases. In our study, we tried to aim to contribute by analyzing a large cohort of patients, about 77 patients, focusing on the benefits of breath hold with PBS, direct comparison between breath hold and non-breath hold plans, and the reproducibility over time of the treatment course using weekly or biweekly QACTs. So this slide gives an overview of our methods and patient cohort. This is a study that we performed when I was at the University of Maryland. We had 77 patients enrolled in an IRB-approved study on IMPT. These cases were fairly diverse, mostly liver, but also a good number of lung and mediastinum cases. Some upper abdominal sites that weren't liver, and a few esophagus cases as well. For all breath hold patients, we used the SDX system to gate the DIVH CT. The system helped us get a reproducible inspiration level set around 75 to 80% of deep inspiration. We also planned for contingency, so every patient had a 4D CT scan as well. If for any reason the breath hold wasn't feasible, we had a backup plan on the average phase and ensured robustness across the motion range seen on the 4D CT. For patients stimulated under free breathing, we applied compression selectively. About 52 of the patients ended up having a belt, and 25 didn't need the belt, so we didn't use that for motion management. Once we had our breath hold and non-breath hold CTs, we generated treatment plans on both of these scans. For the non-breath hold plans, the target's the ITV, which makes sense because you're trying to account for the motion. For the breath hold plans, we prescribe to the CTV directly since the motion is essentially minimized. I should warn, there is still, literature does report residual motion. At most, the upper limit of this residual motion in breath hold is about 5 millimeters. We use robustness optimization for all the plans. For lung cases, we went with 5 millimeter setup and 5 millimeter range. For everything else, we use 5 millimeter setup and 3.5% range. And we held the plans to a standard criteria, which is common in most centers. 95% of the targets should get 95% of the dose in the worst case scenario. Of course, both sets of plans, breath hold and non-breath hold, were reviewed by a radiation oncologist, and they were considered as clinical plans. And then we did IMPT QA for these using a 3% dose, 3 millimeter distance to agreement criteria, using a 90% absolute gamma pass rate. To assess how reproducible our breath holds were over time, we looked at 62 QA-CTs from a subset of 30 patients. And we wanted to see if these patients could consistently hit the same breath hold level and what that meant for the anatomy and the dosimetry. We compared the breath hold and non-breath hold plans in terms of target size, coverage, OAR dose limits. Basically, did things hold up over time and across the scans? And for the stats, we performed t-tests to see if any of the differences that we were observing were significant. This is an example of a lung patient where we compared the breath hold plan to a non-breath hold plan, both prescribing the same dose, 66 gray. So you can see on the breath hold plan on the left and the non-breath hold plan is on the right. One of the first things to notice is that using breath hold allowed us to reduce the target volume by about 20% in this case. That's the yellow contour you see. And the tumor motion range is more controlled during the breath hold. So as a result, we don't have to account for as large as an uncertainty. And so hence we have a smaller target. We also saw better GTV conformity with the breath hold plan. So the conformity index in this case improved from 3.3 in the non-Breath-Hold plan to 2.37 in the Breath-Hold plan for the GTV. And that translates to real clinical advantages. So we saw for this patient a drop of about in the high dose lung volume, about 30% actually. V20 went down by 30% in the non-Breath-Hold plan. And the mean heart dose was cut in half from 2.3 to 1.1. The dosimetric differences does offer they do highlight the Breath-Hold that Breath-Hold can really benefit for acid cases, especially in terms of sparing and surrounding organs. Across our entire patient cohort of 77 patients, the average GTV motion was about 7.4 millimeters. We looked at two groups, patients with abdominal compression and those without. Interestingly, motion wasn't drastically different between the two groups, 7.6 versus 7. But keep in mind the compression patients had larger motion range initially to start with, and the compression did help us reduce the range down to this level. We found that the motion, for cases where the motion was under 3 millimeters, we didn't really see a benefit in terms of reducing the CTV size. But for motions that were beyond that, there was pretty clear trend. For every additional millimeter of motion, we could expect about a 6% reduction in CTV when switching to Breath-Hold. Overall, the Breath-Hold led to about a 20% reduction on average. If you look at the figure on the top right, we see a strong linear correlation between Breath-Hold and non-Breath-Hold CTV volumes, with Breath-Hold plans generally being smaller. In the lower plot, you see the relationship between the CTV ratio versus motion. And again, you can see that the higher the motion, the greater the reduction in CTV when using Breath-Hold. When we break it down by site, Breath-Hold does give us about 21% reduction for liver, 18% reduction in the CTV size for lung, and about 30% reduction for upper abdominal and pancreas cases. The takeaway here is the higher the motion, the more benefit we get from Breath-Hold in terms of shrinking the target volume and potentially sparing nearby organs. Breath-Hold planning did lead to a pretty meaningful reduction in dose to surrounding organs at risk across different sites. Starting on the left, we look at the healthy liver dose for 32 liver patients. On average, Breath-Hold brought about a 14% reduction, but for some patients, the reduction was as high as 42%, and that's pretty big. In the middle, we show lung V20 for 21 lung cases. Again, Breath-Hold helped us reduce the lung volume, getting 20 gray or more, by about 26% on average and up to 43% in some patients. That's, again, quite relevant in terms of toxicity. And on the right, the abdomen and pancreas group, we saw that kidney dose came down by about 24% on average, with some of the patients showing drastic reduction up to 92%. And across all these three groups, the correlation between the Breath-Hold and non-Breath-Hold was very strong. The chi-squared values were about 0.87, reinforcing that this wasn't just random. The Breath-Hold planning does consistently improve OAR sparing. Looking at how CTV and OAR dose reduction tracked with each other, we saw a strong linear correlation between the Breath-Hold and non-Breath-Hold doses, which gave us a confidence that the reductions weren't just noise, they were real and consistent. What's more is that CTV shrank. When the CTV shrank more, we generally saw a better reduction in OAR doses as well that was statistically significant. Across the board, Breath-Hold did lead to lower mean and max doses for most OARs with statistically significant values. On average, we saw 21 to 30% reduction in structures such as heart, stomach, esophagus, and kidneys. Even if you look at max doses, we found sizable drops. So D.03 cc here in this case, large bowel was about 32%, small bowel 22%, and spinal cord 18%. Overall, Breath-Hold gave us meaningful and consistent improvements across targets and OARs. We looked at how reproducible the Breath-Hold plans were over time by evaluating 62 QA-CTs. On the left, we see CTV1, that's the main target, had excellent volume reproducibility, staying within about 1.3% of the original SIM. CTV2 generally represents a secondary or elective volume. It's smaller, maybe more difficult to localize, and so variation was a bit more, it's 7%, but acceptable. On the right, we are looking at a target coverage, specifically V95 for CTV1, and the majority of these cases were within a few percent of the planned dose, which is quite solid. In terms of the dose, we found that V95 and D95 and mean doses for CTV1 stayed within 3%, and the max doses was within 5%. So overall, we are seeing that the breath hold technique is not only effective, but reproducible across the treatments. Here we looked at reproducibility of OAR doses across repeated QA-CT scans on the breath hold. What's reassuring is that even for organs that move with breathing, that's organs such as lung or liver, we do see a pretty tight consistency. The changes in mean doses for liver, stomach, and heart stayed about 0.6 gray. And for kidneys, it was a bit more stable, about 0.2 gray. Lung V20 also held up within 3%, which is great considering the variability in breathing motion and the breathing introduces. The esophagus did show a bit more spread within 1.7 gray, which was still, we felt, clinically acceptable. Overall, this gives us confidence that with breath hold, we are not just getting the symmetric benefit, but we are able to consistently deliver these benefits across fractions, even for mobile organs. Using breath hold, to wrap up, using breath hold can help tighten up our margins and reduce dose to normal tissues. Not only does it make the plan more robust, but also we saw a consistent reduction in the target volume, about 20 to 25%, especially when the patient had more motion. So when they moved during free bleeding, the more you see the motion during free bleeding, the more benefit you're going to get from breath hold. Organs such as lung and liver, which do move a lot with breathing, showed the biggest reductions. Again, that's about 20 to 25% range was the reductions we saw. Even for other organs at risk, we saw benefits. So we saw about 30% reduction in mean doses and 35% reduction in max doses in some of these OARs. We found a clear correlation between how much the CTV shrank and how much dose we spared for OARs, which gives us more confidence in the dosimetric value of breath hold. Basically, the more you can reduce the CTV margin, the more you can reduce the motion range or the margin associated with the motion, the better your OAR sparing is going to get. And finally, we looked at the reproducibility of the QA-CTs for both target volume and OAR doses, and these were also fairly consistent, which is important for a technique that may seem a little tricky to implement clinically. Overall, breath hold did help us cut down on motion-related uncertainties, especially for thoracic and abdominal tumors. And in turn, that makes IMPT delivery both safer and more effective. This study was conducted during my time at the University of Maryland. I'd like to take a moment to acknowledge the many collaborators and mentors and dosimetrists and therapists at the University of Maryland who made the work possible. I, in particular, want to acknowledge Dr. Stina Musahebi, who served as a senior author and provided clinical leadership throughout the study. Thank you.
Thank you very much, Pouya. We do have time for some questions here, so feel free to write them in the chat and we'll take some time to answer them. Okay, so we do have one question. During the IBH treatment, that may take 2 to 4 breath holds to deliver the total dose. Do you use CBCT to verify internal tumor position on the second, third, and fourth breath hold, or do you assume it is the same as the initial X-ray image?
So it depends from site to site. I've used the system at 2 different sites now, and we are in the process of implementing it here. The initial setup is usually with CBCT, and you can, if the patient goes out of breath hold, you can resume that CBCT. Typically, if the treatment duration is long or there is a reason for or a concern, you may decide to repeat the CBCT at some point during the treatment. Another option that we did at a different site was we would take KV images and compare diaphragmatic motion prior to beam delivery for the remaining fields. So it's not realistic to be taking CBCT for every field. But if the treatment ends up being long or there's certain reasons or concerns, we do consider repeating CBCT.
Thank you, Pouya. We do have another question here. So Did you ever speak with patients about the difficulty to do the training with this parameter, the SDX? I believe there was a part in your study where you talked about patient acceptance of the device. Do you want to comment on that?
Well, I mean, it's not obviously one of the things that we saw is that the treatment duration would go down as the patient would, I guess, evolve in the treatment because the patients do get better with performing the breath hold. The criteria we had selected was the patient would it's required that the patient hold their breath for about 20 to 30 seconds. If the patient can do that effectively and repeatedly, then they're a good candidate for the system. And
Mhm.
as the treatment evolves, the patient does get used to performing the breath hold, and so the treatment duration does become shorter and shorter, and they actually are able to maintain the breath hold even slightly longer than the initial phase. But that is certainly you have to vet the patient before you decide if they're eligible or not for the breath hold.
Absolutely. The preparation of the patient is definitely the most important step here. Okay, we do have more questions in the chat. Do you have the statistics to show the difference with and without breath hold for the CBCTs?
Hi, Baekwan. It's good to hear from you. We didn't analyze the CBCTs in this study. We relied more on the QACTs because the goal was also to do the dosimetry calculation. I do think that is something valuable to do, actually, to go retrospectively and look at the reproducibility in CBCTs, especially because you would have significantly more data, and you would obviously that study then would just be a discussion on positional accuracy unless you start making more or adopting more sophisticated techniques to calculate the dose. But no, for this study, we did not look at that.
Okay. We have another question about CBCT. How did you take a breath hold CBCT on proton machine, for example, IBA, Proteus 1, or Proteus Plus?
This study was performed on the variant system, and one of the things that we did test was some patients they couldn't take they may not be able to hold the breath hold during the entire duration of the CBCT, and at that point, then you do pause the scan and resume once they enter the breath hold again. Or you can use a half fan scan to get a faster acquisition and so on.
Mhm. We have another question. Do you recommend to use SGRT while you are using SDX for moving tumors? Like, do you recommend matching both techniques? I think it's a great question.
It's a great question. In fact, in the old spirometry systems such as ABC, that do have this drift issue, um, there is several studies that talk about how you can try to inform the spirometry with the obtaining an additional surrogate in order to using both of them to account for the drift and so on, the effect of drifts and so on. If both systems are available, it's a great study to do. Um, Oftentimes, and so if both systems are available, I think it's a great study to do. For SDX, given that you're treating in breath hold, I'm not sure how necessary that would be. But for example, perhaps one thing that I myself have never been really comfortable with is using just the external surface of the patient in order to deliver gated treatments or breath hold treatments for something that's far into away from the breast. So for breast, I understand doing that but for internal tumors such as tumors in the abdomen or lung, I am a bit cautious about this idea. And so I think perhaps using SGRT, performing such a study where we have SGRT along with a more reliable system such as SDX, you could perhaps try to gain some confidence in how well that breath hold is reproducibility is shown with the SGRT system.
Okay. I heard about some technical difficulties also with SGRT systems. Like if the snout gets very close to the patient, then you can lose some signal. Do you have a
That's
comment on
yes.
that?
So I've used the CRAT system and before for say breast treatments, and that's definitely one issue that you do get because you try to get that range shifter as close to the patient as possible, for most plans. In lung plans, there may be as I mentioned, there may be a desire actually to blow up the spots slightly so that you get a more robust plan. But in those cases, it does occlude the vision of the camera. So you do, and then it is limited. So you may be able to see the abdomen, but depending on where the range shifter is and the snout is, but it does occlude the camera. It could occlude the camera.
Okay. All right. Next question is, would you favor using beam efficiency improvement techniques such as reducing spot number, layer number, raising minimum MU per spot to further improve breath hold tolerability and efficiency, making it less breath holds per treatment?
When one of the things that one type of treatment that we did there was also grid treatments. And so these treatments are a single field, and typically the proton grids are single field from a single direction, the way we were planning it. And for those plans, there was a desire to try to improve treatment efficiency. At the same time, there is residual motion, so that you have to worry about. The residual motion is reported to be below 5 millimeters. So I do think it's a good idea to try to reduce the delivery time, the beam delivery time, in order to reduce the need for multiple breath holds. On average, I think what we reported was we had about 2 breath holds or 2.5 breath holds per beam that we treated. And so you can imagine if a lung patient has anywhere from 2 to 3 beams, then you're talking about 6 to 7 deliveries. So I think it would be worthwhile to look at some of these techniques. At the same time, we would have to perform some additional studies to make sure that the plant degradation is not significant respect to these residual motions. Which I don't think it would be because the range of the motion is fairly small.
Okay. We have 2 questions from our colleagues in the UK. So they're asking for your current setup at the center. And also, do you look at motion and 4D first and make a decision or decide based on upper and lower lobe tumors?
You can make you definitely, typically by the time the patient comes in for the simulation, you have a fairly clear idea of if you want to do breath hold or not. And mainly because you should, unless you want to start coaching them at the simulation session, which it's advisable to, I think, perform coaching beforehand to reduce the duration of the simulation session. So you could do that. You could, for example, even to criteria for compression belt, we look at the motion range and we decide upon if the patient needs the belt or not. But at the same time, just going by the tumor site is a good indication of if the motion is needed or not. I think by the time the patient walks into the simulation room, the physician does have a pretty good idea if they want to do breath hold on the patient or not.
Okay. And so the same person had a different question. Can you estimate, although I know it is difficult, how many patients with lung cancer you see are only treatable with breath hold, such as you can only meet the constraints, likely the V20 with spirometry-based approaches like SDX?
I think I can't I can't comment on that. I can tell you, I've showed you what the reduction is
Hmm.
and in this presentation, and I've also shown what the expectations in the reductions are as a function of motion range. And I think that's something that's fairly valuable because if you have a tumor, if you have a lung patient in mind and you have an idea that this patient's tumor is moving about 1.5 cm, then I think very quickly you can use some of these statistics to arrive at what would be the beneficial gain in reduction in CTV size, for example, from using breath hold. So those things I can comment upon. What the dosimetric impact is, it's much more difficult because it's very patient specific and tumor specific and so on, depending on where the site is. And so those I really can't comment on that.
Okay.
It's a good study, though. I think if we acquire a large enough patient cohort, we could maybe try to figure out some correlations and statistics based on the site and the location.
Okay. Um, Another colleague here in the US says he's curious about the SDX implementation for Proton Arc in the future. Did you hear anything about that,
I
Pouya?
have not. I have not.
Not
I think
yet.
maybe talk to the Beaumont folks to see what they recommend.
Okay. And we'll know more during PTCOG NA at the end of the year, probably. Another question, does the use of a belt system result in non-reproducible, I guess, deformation of the anatomy?
Certainly, and depends on the site. So, for example, if you're treating a lung tumor, then perhaps using a belt is not because the belt will be completely out of this maybe out of the field. Then I don't see an issue to using the belt. But using abdominal compression is something that we are also here at my current center are hesitant in towards just applying to all the patients. For abdominal patients, the belt can get in the way. It does deform. It does, I think, smoosh everything together, deform the anatomy. Also, the reproducibility on the skin. It does pull in the skin, and then how that's being reproduced every fraction. These are I think common concerns. And with the SDX system, you don't need to put the belt on. So this is the belt. The goal of the belt is to reduce the motion under the free breathing conditions.
It is a very interesting question because I believe the person that asked it is going to be using upright. It's going to be doing upright proton therapy. So
Hmm.
I guess it is important also for their setup. Well, that was a lot of great questions. We still have some time, so feel free to use the chat or the Q&A if you want to know more about SDX and motion management. Also, I didn't comment on that, but you have the contact of Pouya here on the slide, and feel free to contact him if you have any questions.
Thank you, Suresh. It's good to hear from you.
Can you
Um,
come? Can you comment about gating treatment, Pouya? I think we are talking about the interface with the machine.
so depends on right now, for example, we are in the midst of I guess commissioning the SDX system using it depends on what on which machine. So you have I think Annabelle, you can comment on which machines you guys support where you have automatic gating, and sometimes you do have manual gating. Right now, we
Yeah.
are trying to integrate, for example, gating with the ETO system, and that's going to have to be manual. So sometimes you do have to rely on the therapist to gate the beam on and off, and sometimes
Mhm.
depending, and the SDX does support some of the vendors with the, maybe Annabelle, you can comment on which vendors you guys support.
Yeah, absolutely. So for Proton, we work with IBA, Proteus Plus, Proteus One. We do work with also Mevian and Variant, and we are starting to talk to Hitachi. Um, and then we are compatible with the Leo Cancer Care upright radiation therapy um, systems, and we do not yet work with Ethos and Halcyon because the current version don't have any interfacing capabilities. That's why you are going to have to treat manually at the moment. But for Proton, we work with all the major vendors, and we are open to working with more.
And then I think I haven't used the system on a TrueBeam, but it does support gating, automatic gating with the TrueBeam. Yes.
For some version of the TrueBeam, it does. Yes, we have to check it's on a, case to case basis. We still have a lot of people connected, so don't be shy. If you have any questions, just send them in the chat. Okay, well, I think we're done here with the presentation. Again, thank you very much, Ouya. It was a pleasure to have you here today.
Thank you. Thank you. It was a pleasure to